Well, welcome back, everyone. Hope you enjoyed a little quick break and some refreshments. We're, as we move from the last session, which was certainly focused around data sciences and data sciences help in our work around population health, we're going to fully move into the global health topic now with a couple of great speakers, and then, as we've done before, with a moderated Q&A session. So first up is a person that many people in this room know and know of, I know. Dr. Bob Einterz is the director of the AMPATH program, AMPATH Consortium, and the director of the Indiana University Center for Global Health. So as many know, AMPATH is a consortium of North American universities in partnership with Moi University and Moi Teaching and Referral Hospital in Kenya. Their primary care and chronic disease management program has successfully served a population of nearly 2 million people in Western Kenya, including more than 100,000 that are HIV-infected individuals. It's a fantastic program, and we're thrilled to have Bob here to tell us more. And welcome, Dr. Bob Einterz, to the stage. Thank you.
Thanks so much for the introduction, and thank you very much for inviting me to speak here this morning. I actually haven't met Lori Leroy, or Leroy. Is she in the audience somewhere? There she is. Okay, so I have met you. So good. When Lori asked me to give this talk, she asked me if I could compress Indiana University's 27-year partnership with Moi University in Kenya into 15 minutes. And in that same 15 minutes, could I discuss the contributions of Hoosier entrepreneurs, innovators, and corporations? I accepted that challenge. And why? Because if, or really should I say when I fail to tell that whole story, I will have illustrated our most important lesson, which is failure is our friend. We fail forward. It's a necessary ingredient for success. And if we can convince ourselves, our bosses, our colleagues, our peers, our students, and our employees of that fact, we will be well on our way to creating an environment which itself creates space to dream. Now, if my colleagues and I, Kenyan and American, have done nothing else over the last 27 years, we have unleashed a new generation of restless leadership. The design of this partnership, the design of our partnership, really sucks in some of the brightest young and not so young minds in both Kenya and in North America. The partnership inspires them with hope. As one of my Kenyan medical students probably illustrates it best, upon his return to Kenya, he sent me a little one-liner. And he said, after having been here for 2 months, I have learned that anything is possible. Now, we have numerous corporations and companies here in Indiana who have contributed to our success there in Kenya. Shapiro's Delicatessen, just down the street, helped bring up a restaurant, believe it or not, there in Kenya. Expo Design builds the floats for the parade, helped bring up a workshop for HIV-infected women to enable them to provide and to build crafts, make crafts to make them self-sufficient. And of course, we've had many pharmaceutical companies and employees from pharmaceutical companies work with us there in Kenya. Lilly, Celgene, AbbVie, Abbott, and many others. And one of them just sent me an email within the last few months, and she said that she had never anticipated working in a developing country. It never even crossed her mind. But she came and worked with us for 6 months on helping to improve the drug supply chain. And after that, she realized that what she wanted to do was work in a developing country. She applied through her company to work in Latin America, did a job there for 6 to 8 months, was recruited within her company to move to India, where she ran a major project, and then was promoted to a team leader position leading a technology transfer team across the entire globe, China, Brazil, India, Russia, and elsewhere. She said, "I would never, never have done this had it not been for my experience in Kenya." Now, thousands of young Americans and Africans have tasted, embraced, experienced this way of risk, compassion, and change. And as my colleague Joe Mammon likes to say, we will not live long enough to see the impact of that leadership, but we are convinced that that experience and that leadership trumps all the obstacles and all the opportunities for skepticism that all of us have to deal with so often in our everyday lives. Well, enough of the future and when I'm no longer here and you're no longer here. I just talk for the next 10 minutes here, a little bit about our program. Got to go back 3 decades. 3 decades ago, a young faculty member, along with his 3 colleagues, convinced a reluctant Indiana university to partner with Moi University in Kenya, a new medical school starting there. The mission was really very simple, the tripartite mission. We were going to, through this partnership, improve health in both countries. We're going to advance research, and we're going to create opportunities for education and training for all. The formula was also very simple. One American linking with his or her Kenyan counterpart, each representing their respective institutions and hence forming an institutional relationship, but the individuals forming individual counterpart relationships, relationships based on trust and mutual respect, and of course, aiming for mutual benefit. And for the first decade of the partnership, it worked fabulously well. But by 2000, there was a problem. And that problem was that HIV was spreading across that continent like the wildfires across California this morning. Spreading across that continent, spreading across that country, and ravaging everything in its path, particularly young, unsuspecting women and their young families. Now, just to try to illustrate for you how it was back then in 2000, think of yourself, and it's going to be hard for you men, women will do it a bit easier, but think of yourself as pregnant, walking to the antenatal clinic at Kisumu, in the Kisumu area along Lake Victoria, and you're walking there with 2 of your friends, each of them pregnant as well. So the person on the left of you, the person on the right of you, and you. Unbeknownst to any of you, because HIV testing is not being done in the public sector, one of the 3 of you is HIV infected, because that was the prevalence in that part of the country at that time, close to 30%. And the likelihood that you're going to transmit that virus onto your child is 50% by 2 years. And the likelihood that that child's going to die of HIV is 100%, certain death. Now, at this same time, in the United States, as you well know, the triple drug cocktail had been discovered that converted HIV from a chronic illness from a certain death sentence into a chronic illness. And though the incidence of death from HIV was plummeting here in the United States, there it was going in just the opposite direction. And even if the medications were available, which they weren't at the time, the physicians and the medical professionals there did not know how to use the medication, and of course, it was far too expensive for the average Kenyan to afford. So you ask the question then, what is a university to do? What is this partnership, this academic partnership to do? Clearly, research done by the best in the world, and I would contend Indiana University is one of them, if not translated, if the outputs of research are not translated into meaningful clinical outcomes for the population, what have we really accomplished? And likewise, if we train the best and the brightest, and I can guarantee you that the Kenyan medical students are the best and brightest, will go toe-to-toe with any of you here. If we train the best and the brightest, but those individuals graduate into dysfunctional health systems, they lose hope, they're spurred to migrate to the city to take care of the rich or to come here to the United States to take care of us, we're happy. But what have we really done for the population in Kenya who are desperately in need of their care? So what we said is we need to try something a little bit different. We're going to change the paradigm. We're going to lead with care. An academic institutional partnership that's going to lead with care. We're going to hold ourselves accountable to the health of the population. Rather than judging our success just in research publications or just in the quality of our graduates. We also need to look at the outcome measures in the population and judge our success on the basis of those. Of course, any system needs a tool. It's the T in the TED Talk, right? To the technology, which the tool, the anvil, the wheel. Our wheel happened to be an electronic medical record. Clearly, you know better, or at least as well as I do, probably many of you better, that the practice of medicine is information rich. And to care for a chronic disease like HIV, or much of what we do, we need a tool to enable us to integrate that complex information and to put it into care. We had demonstrated, and by the way, when I say we, don't think people that look like me, and as I'm looking at this room here, look like you, okay? I can't really see y'all very well. We as Kenyans and Americans working together under Kenyan leadership, and they're in the driver's seat here. It was our privilege to be working alongside them. But in the late 1990s or mid-1990s, we had demonstrated proof of concept of an electronic medical record in a rural health center in Kenya. And so now we took that electronic medical record, and this is particularly by individuals in the Reagan Street Institute, overhauled it, and created on an open MRS platform a very robust electronic medical record that enabled us to deliver care and, of course, welcomed cutting-edge technology, which enabled us to make the discoveries that we need to make, and of course, to help us change course as we charted it. So working in partnership with the Ministry of Health and doing all of this in the public sector, we created what we called AMPATH, A-M-P-A-T-H, Academic Model Providing Access to Healthcare is what it means now, then Academic Model for the Prevention and Treatment of HIV and AIDS. With a donation of $60,000 from an infectious disease doctor here in Indianapolis, we started 45 patients on therapy, 15 in a rural area and 30 in an urban area, recognizing that what works in the city doesn't necessarily work in the country, and what works in the country doesn't necessarily work in the city. From there, we put everybody else on waiting lists, and we worked to find the capital to make this baby hum. Over several months to several years, our program grew from 2 clinics to 25 clinics, from 25 clinics to 100 clinics, from 100 clinics to 500 clinics, where we're at now. 500 sites spread across a population of 4.3 million people. Now, you all know that this virus is sexually transmitted, but the root cause of this pandemic goes far beyond sex and far beyond this virus to matters of gender disparity, food security, and income security. I noticed on the runner of one of these slides in the last presentation, somebody had made the comment that 80% of healthcare has nothing to do with the biology of healthcare, if you will, but it's more related to social determinants. I'm not sure they use the term social determinants. But clearly, if we're going to be successful in taking on this epidemic, we need to look beyond pure medical care. Medical care is a failure. So I like to say, well, we have to address food security. People are starving, right? People are starving. I like to say, well, we're Hoosiers, you know? We're Hoosiers. We know how to farm. And for those of us with stethoscopes around our neck, you know, we actually created farms. And we went in partnership with the World Food Program. And we started to feed thousands and successfully fed thousands of people. But of course, that was a failure, right? Because what's sustainable about creating your own farms? There's nothing sustainable about that. That's not going to work. And so reaching to our colleagues at School of Agriculture in Purdue, up the street to Dow AgriSciences, we worked with the experts, if you will, linking them with their Kenyan counterparts, and were successfully able to create very robust farm extension programs, targeting particularly the smallholder farms. And we went beyond that, this particularly led by our friends up at Dow AgriSciences, in creating farming cooperatives to the point where now we have numerous farming cooperatives, each with the potential to bid successfully on tens of thousands of dollars of forward delivery contracts. Income security, of course, that helped income security for some of our population that we serve, but income security in a dirt poor place like Kenya, average annual income somewhere between $300 and $600 a year, was a different story. We initially tried microloans, microfinancing, where we were the lender, failed miserably. Then we stumbled on the power of groups. I like to think of it as, kind of like the foundation of American democracy, right? De Tocqueville, the power of group associations. Same thing in Kenya. Individual groups of relatively poor, very poor individuals loan to themselves in a process that we refer to as tabletop banking. And if done in a particular way, can be phenomenally, and in fact is, we've shown, phenomenally successful in enabling individuals to get up from the bottom rung of the ladder to the next rung of the ladder. A path toward sustainability and, of course, celebrating entrepreneurship. I love the little comment by Muhammad Yunus, the Nobel Prize winner, who said that no man, human beings weren't made to work for other human beings, right? And women, for sure, were not made to work for men. And so this, again, is celebrating the entrepreneurial spirit. So we were feeling pretty good about ourselves. We'd spread out across western part of the country. We were addressing the social determinants of health. People were coming into our facilities, and we were feeling pretty good about ourselves. Unfortunately, if you remember that example that I told you about 30% of the women coming in HIV infected and not knowing it, we're addressing that. But we weren't getting out into the community. And what we discovered was that if you went beyond the walls of the facility and into the community and found the women who were pregnant there and weren't showing up to the antenatal clinic, the prevalence of HIV in that population was 3 to 4 times the prevalence of the HIV in the population of women coming into the antenatal facilities, antenatal clinics. But also, as I would guess some of you know, if you can get that woman on antiretroviral drugs early enough in her pregnancy, you will cut the incidence of HIV at 2 years from 40 to 50% to less than 3%. So the solution, I think, is pretty obvious, right? You can't stand in your facilities to take care of these patients. One needs to move beyond the facility into the community. We organized community health workers, testers, counselors, and we went door to door, knocking, and again, we, not me, right? Think Kenyan. Knocking door to door, and the results were astonishing. 98% of our households opened their doors and welcomed these testers and counselors and community health workers in. And we were able to enroll virtually every single individual in our community, identify virtually every single infected mother, and we were successfully able, at a population level, to cut the prevalence of HIV, or the incidence, if you will, of HIV in those newborns from 50% to less than 3%. We were feeling pretty good about ourselves. But there's another problem. HIV is not the only problem there, right? I mean, there's this burgeoning parallel epidemic of non-communicable diseases, diabetes, hypertension, oncology, been there all along, but even more prevalent now with the aging of the population. And of course, the diseases of poverty never went away, maternal, neonatal, child health. Why don't we take this very successful HIV treatment and control program, addressing social determinants of health, now community-based, and transition it into an integrated healthcare delivery system that addresses all patients and all major health problems, and do it all in the public sector, which is where 90% of the people get their care. And so that's where we are today. Of course, our initiative, we call it, like you were talking about population health before, our population health is where the denominator is the population. The denominator is the population, and we are bringing up centers of excellence in oncology. Lily's done a terrific job of helping us with that. In oncology, in cardiovascular diseases, addressing hypertension, and of course the #1 burden of illness worldwide, if you lump them together, mental health, mental illness, #1 burden. We're beginning to address all of those issues, all undergirded by the power of the electronic medical record, and all of it based on this basic principle of institutional and counterpart relationships. Of course, for a population health approach, you need more than just an effective delivery system. You need a way to finance it. and we're working on that as well. Here, in partnership with the National Hospital Insurance Fund of Kenya, we're working with them. They have developed an insurance package specifically for the poor. It costs the poor about $5 per month, and it will provide all essential health care if they can get into our AMPATH delivery system. Of course, $5 per month to you sounds super cheap. To someone making just $300 a year, that's a bundle of money. So there are all these issues of how does one market persuade, cajole, convince individuals to purchase the insurance? What do you do when their money runs dry for just a month and they can't afford it? So these are some of the challenges that we're dealing with and figuring out currently. I would, in closing here, just like to read to you some of the statements that I have received from specifically some of the Lilly employees who have participated in our program. I've talked about what we have done to help improve healthcare in Kenya. I've not talked about how we've taken some of those lessons and applied them here, that we have. Our use of community health workers, for example, we're applying in some of the low-income areas of Indianapolis as well as eastern Indiana to address issues of maternal mortality and infant mortality, and as well the AMPATH electronic medical record that I spoke about has now been exported from Kenya, developed for Kenya, right? Exported now, and OpenMRS is being used in more than 60 countries worldwide. Those are just a couple of the examples of bidirectional innovation that have come from this program. But perhaps most important, of course, is its effect on the leadership of the next generation, the leadership of today's generation. Jamie writes, "This was one of those life experiences that has permanently enhanced my life for the better and will live beyond me to my children." It sounds hyperbolic, hyperbole, doesn't it? But in my 27 years of running this program, it's true. It will live to her children. Dyron says, "The two things that were reinforced by my trip to Kenya, relations are always more important than a project. Sometimes people just need a pat on the back." Carla from the Netherlands, "It's been an amazing experience that has been life-changing on both the personal and professional level. It has changed my perception of the world around me and of healthcare." I love this comment from Mark, Western Australia. "It's hard to believe it's been nearly a year since our time together in Eldoret. The fond memories and lasting relationships are still so vivid. The year that's nearly passed has been met with new perspectives and appreciation for my life as well as the work I do. I've learned to be a lot more patient with my kids." Go to Kenya, you'll be more patient with your kids. "With the people I work with and with myself. I try to do the Kenyan thing of taking time to know someone first and understand their context. It's amazing how much smoother that makes things." And then Sylvan from the UK, after working with us and contributing. "It required all of us, a very large and unique blend of knowledge, skills, and talents to bring innovative medicines to the patients. The experience served as a formidable reminder of why we do what we do every day in the research lab." In closing, again, just go back to what I said in the very beginning. If we can create the space to dream, to risk, to fail, and to dream again, I firmly believe that we can make ourselves and our world a little bit better. Thank you so much.